Thank you. I do very much appreciate the opportunity to be here, and I will apologize in advance for descending from the sublimity of global health and the bigger picture of telehealth to the very local and regional experience that I have had here. But they say all politics is local, so maybe a local example of how a telemedicine program has developed and evolved will be of some value to those of you who are thinking about doing it yourselves. I will start with a couple of very familiar patients that I've presented before, but I think they illustrate some of the issues related to the use of telemedicine, not just in burn care, but in many other aspects of care. And this is a patient from several years ago. He was a 60-year-old man about whom I was called by an emergency room physician from a remote small town. And let me say at the outset, it's not my intention to make fun of local emergency room physicians. This was a well-intentioned doctor trying to do the best he can. He simply didn't know much about burn care, and burns are such a small field in the United States that many people don't know a lot about burn evaluation and treatment. His patient was a 60-year-old man who had a fire in his garage. The patient suffered burns to his face, scalp, and hands. The physician estimated his burns at 15% of the body surface area, which would make it a moderately severe injury. He thought that the patient had extensive facial injuries, which raises the concern about airway support and intubation, and he wanted the patient transported to Salt Lake City. I was able to talk him out of intubating the patient, but I really didn't have a clear idea what I would be presented with on the patient's arrival. This is what he looked like on arrival and evaluation in the burn center. Most of his burns, in fact, just turned out to be soot that was on his face. They washed off. And I estimated his burns at about 3.5% of the body surface area. Obviously very superficial injuries, no threat to the airway, no significant smoke inhalation. His hospital course evolved over the next couple of days. It took us about 10 minutes to take care of him. We washed him off and put on some ointment and gave him some oral analgesics, and he was very happy with that. But he had to stay in the hospital for 2 days because his family had to come down from Montana and get him. And like many Montana families, they had to get off work and get gas in the car and stop the mail and feed the dog, and then they had to drive 600 miles to pick him up and learn his care, and then they had to drive all the way home. In 2005, the hospital here charged him $4,700 for 2 days of hospital care. I charged him $166 for an initial history and physical, initial debridement, and a follow-up day of care. His air transport cost $14,000. That was in 1985. Last year, a similar transport cost about $30,000. And it was not too long ago, and maybe that day is still here, when many hospital administrators would say, "That's great, a $30,000 air transport. We can really use that money, and we didn't even have to take care of the patient." That's an example not only of the use of resources for medical care in the United States, but of the abuse of resources and the misuse of resources in the United States. This guy clearly did not need a $30,000 air transport, and the overuse of air transport and triage situations in the United States is a real problem. The next patient was another man about whom I was called by a remote emergency room physician, another 60-year-old man who was priming a carburetor. I won't explain to the younger people in the audience what carburetors are, but they used to be part of your car. He had burns, he said, all over his face, and he was very concerned about intubating the patient, who was a good 4 or 5 hours away from the University of Utah. I didn't really think, based on the story that I had heard, that the patient needed to be intubated. And I asked the doctor if he could send me a digital photograph, and the doctor said, "Well, I don't have a camera here." So I said, "Well, do you have a cell phone?" And he said, "Well, yes, I have a cell phone, but I don't know how to take a picture with it." And I said, "Well, that's okay. Go out to the waiting room, find a 12-year-old girl. She'll show you how to do it." So he took a digital photograph, which I didn't include here. He sent it to me. That man looked a good deal like the first man. He didn't require a $30,000 air transport. He was able to stay locally. I was able to advise the physician about some care. The patient and his family, of course, were thrilled that they didn't have to come all the way to Salt Lake City. And while, yes, we lost the income associated with the air transport and the hospitalization, I think that the savings that we produced made this more than worthwhile. And this is a very simple, very basic illustration of how telemedicine can work. This is telemedicine at its most basic, and it's exactly the kind of an example which could be applied, I think, in a third world situation or really almost anywhere where patient care is delivered. In the United States, we face an interesting problem. The incidence of burns is decreasing due to smoke detectors and product safety legislation and water heater controls and a variety of other things. So that instead of about 10 burns per 10,000 Americans in 1971, we're down to about 4.2 burns per 10,000 Americans today. The incidence of burns has gone down very substantially. We're very happy about that. But as a consequence, the number of burn centers has also declined. Burns have not been very well reimbursed in the past. Many hospitals have not wanted to devote the resources necessary to develop burn centers, and most of the remaining burn centers in the U.S. are located in academic medical centers, which isn't much of a surprise. This is a study that Matt Klein from the University of Washington published, which shows the access to burn centers in the United States. On your left, I believe, are verified burn centers, those burn centers which are verified by the American College of Surgeons. And on the right is anybody really who considers themselves to be a burn center. And as you can see, the travel times to many burn centers are very substantial. The gray circles illustrate 2 hours of helicopter transport to get a patient to the local burn center, and the darker circles represent 1 hour. As you can see, there's a huge area of the western United States that is not within access of a burn center in a reasonable period of time. And for some of these people, the travel times can be 8 or 10 hours, even in an airplane, to get to an appropriate level of specialized care. Because the incidence of burns has gone down, the expertise available by practicing physicians has also greatly declined. Many physicians in the United States receive no training in burn care during their residencies, and even many surgeons don't rotate through burn centers, as a consequence of which the care tends to be concentrated in the few remaining centers, and many people really have no expertise or knowledge about the evaluation of even the most simple burn. In the international setting, the problem is exactly the opposite. In the United States, we have so few burns and so few burn centers that we have a hard time delivering effective care. In the rest of the world, there are so many burns and so few burn centers that access to care is even worse, and the global problem of burns as a public health problem are very significant. 90% of the world's burns occur in low and middle income countries, half of those in Southern and Southeast Asia, 300,000 deaths a year worldwide. The mortality from burns is 5 times higher in Africa and 10 times higher in Asia than it is in the United States. And that's just the data that we have. Much of this data is significantly underreported. I read an article last night from Kenya which estimated an incidence of burns in one rural suburb of Kenya 70 times higher than it is in the United States, and most of those burns occur in small children under the age of 5, which means that even if they survive, and most of them do, they may face a lifetime of disability and disfigurement, and in many cultures, very substantial social ostracism from the physical and visible scars which result as a consequence of the burns. So this is, in my mind, low-hanging fruit for a telemedicine program. Very, very simple, very, very basic telemedicine could deliver very substantial improvements to care if you can simply get an image of the patient to somebody who knows what they're looking at. So with that in mind, we started a demonstration project in 2005, which was grant funded. We had a relationship with 3 hospitals in the Intermountain West, 2 in Montana and 1 in Idaho. We established telemedicine communications with them, and we began looking at their patients. And as you see in the red circle, in the 2-year period of time prior to the institution of this project, we saw about 28 patients from these 3 facilities. In the 2-year period of time following institution of the project, we saw about 3 times, almost 3 times as many patients as we had seen before. Fewer of those patients required transport, only 44% required transport. We were able to keep the other patients locally because we could evaluate them, even though the physicians might have been very nervous and very anxious about treating any burn injury on a local basis. And the families, as well as the patients, as you can imagine, were delighted to have this service available. One of the local hospitals advertised our availability through telemedicine as part of their marketing strategy, which I think you're seeing done more and more around the United States now. When we looked at the evaluation of burn extent done by the referring physician and the evaluation of burn extent done by the burn center physician, as you can see, there wasn't very much correlation. Some of the physicians we dealt with were wildly inaccurate in their estimation of burn size, which led to potentially very significant errors in fluid resuscitation, the decision to transport, airway management, and other things. In contrast, the evaluation of burns which we were able to perform by telemedicine compared to the evaluation of burns when the patient arrived in the burn center, was very, very accurate. And that validates the use of telemedicine as a way of evaluating burn extent and depth. The pictures that we got were of very good quality. We were able to evaluate the burns very accurately using telemedicine. So since that time, our system has continued to grow. The grant ended in 2008, and our referrals did initially go down, but they've gone back up since then. We will see over 300 patients in our weekly telemedicine clinic this year, and these are really only the visits that we see in two-way real-time video communication. It doesn't include a very large number of what Patricia calls asynchronous or store and forward communications. I get sent pictures of patients by doctors all the time, and often a single photograph is all I need to be able to provide very appropriate advice about the evaluation and treatment of a minor burn. I think that could easily be done internationally as well. So here's another example of the kind of injury that really benefits from telemedicine evaluation. This is an injury that we are seeing more and more of, and if you're involved in pulmonary medicine, you can probably guess what happened to this fellow. He was wearing his nasal oxygen cannula and decided to have a cigarette, and when he lit his cigarette on nasal oxygen, the nasal oxygen exploded. And this sounds like a crazy thing to happen, but it really happens all the time. We probably get at least one call a month about somebody who was smoking on oxygen. Now, when this injury occurs, it sounds very severe. I mean, it's oxygen, and they make rocket fuel out of that, and anybody that inhales that burning oxygen must have a very significant injury. And many well-intentioned local physicians are very tempted to intubate these patients because they're afraid of the consequences of inhalation injury. But in fact, you don't really get an inhalation injury from nasal oxygen. There is a flash fire. It's over with in a second or two. You generally burn about the first centimeter of the inside of your nostrils and nothing else. And even though this guy's beard could have caught on fire, which would have been a real problem for him, it didn't. So he's got a little charring around his nose. He's got a burn of less than 1% of the body surface area. When these patients are intubated and transported to us intubated, they are a big problem. They are very hard to get extubated again. And if we can avoid intubation with a little bit of appropriate advice and evaluation, sometimes the patients don't need to be transported at all, and even if they need to be transported, they can go home the following day. So again, this is a situation where one photograph and a very brief telephone call can obviate a huge amount of expense, a potentially lethal complication, and a huge amount of inconvenience for the patient. This is a little girl named Cassidy. She's a friend of mine. She was burned up in Poplar, Montana when she was cooking and came to Salt Lake City to have skin grafting on her hands and forearms. And here she is, seen by telemedicine, doing her physical therapy. She's got a lot of problems with scarring and contracture. The local physical therapists, of course, don't have any burn training, and she sees us regularly on telemedicine so that we can work on her physical therapy and a range of motion. She's a Native American girl. She doesn't really have a lot of resources, and the ability to connect to her with telemedicine has been a real boon to her. This is just a map that shows you the places that we have been connecting to for our telemedicine service. Montana has a very extensive, very well-developed telemedicine network, and so does the Indian Health Service. So most of these are not telemedicine studios that we established or we put in place. We simply took advantage of the networks which already exist. And the point that I would make to you is that Cassidy lives in Poplar, Montana. Poplar, Montana is 890 highway miles from Salt Lake City. This little girl would never be able to come to Salt Lake City for a routine clinic appointment. And even if she was to fly, she would first have to drive to Billings, which is about 250 miles from her home. So at the very least, it would take her all of a very long day, or more likely 2 days, to come to Salt Lake City for a 10-minute clinic visit. It's safe to say that without telemedicine, she would have had no access to follow-up care, and her long-term outcome from a range of motion standpoint is very, very seriously affected by our ability to provide her with post-op physical therapy and physical therapy advice. So here I am looking at TV like Patricia showed you. This is the kind of the standard impression that most people have about telemedicine. They think of it as two-way synchronous video connections, and those certainly can be done. They can be done much more cheaply now with iPads and laptops and desktop computers, and that is the system that we are trying to institute more and more of in our hospital as we move forward with the telemedicine program. These are all store and forward images. These are pictures of patients that the patients sent me, and they prove very, very valuable in terms of evaluating patients and giving them their follow-up care. The upper left-hand corner is a picture of a little boy with a burned arm. The lower one is a little boy with a burned chest. In both cases, these pictures are taken about 2 weeks post-op. I was able to look at the photos and tell Mom and Dad they didn't have to come to Salt Lake for a clinic appointment. Just take another picture and send it to me in a couple of weeks, and I'll let you know how this works out. The upper right-hand corner is a big wound that I was able to advise a local surgeon about, and the lower right-hand corner is a picture of a little boy's leg after skin grafting. This is a follow-up clinic appointment. Again, the patient didn't have to travel to Salt Lake, and we were able to get a good look at his wound relatively easily. One of the big concerns that everybody has about telemedicine practice, particularly in the United States, is reimbursement. And there's a very widespread misconception that telemedicine will not be reimbursed. In fact, much of the time that's not true. And since we didn't know that when we started our program, we simply sent people bills just like we did everybody else. There's a simple modifier that can be used for telemedicine. And as this graph shows you, our reimbursement rate for telemedicine burn care is exactly the same rate as for our regular outpatient clinic. Now, that's both the good news and the bad news. The reimbursement isn't always that good, but it's as good as it is for everybody else, and it is as good as it would be if the patients drove to Salt Lake. Some of these patients are unfunded. Some of them are post-op patients, and their care is bundled, so we can't really bill for a post-op visit anyway. But we do just as well out of telemedicine as we do with any other system. There are now bills in front of Congress which would do two very, very valuable things for telemedicine. The first is that it would create a system of national licensure, so you don't have to apply for state licenses all over the Intermountain West. A Nevada license, for example, costs $1,000. It takes about 3 months to get. It's a tremendous amount of time and trouble, and unless you're doing it on a regular basis, you're probably going to decide that it's not worth doing. Federal licensure would obviate that problem. It's also going to increase the compensation for care that is delivered by telehealth, which is already making progress in the United States. 15 states currently have laws which stipulate that any care that is delivered by that would be reimbursed if delivered in person will be reimbursed if delivered by telemedicine. 2 more states have approved these bills and they are awaiting signature by their governors. I'm delighted to say that Montana is one of those, and 12 more states are moving ahead with this legislation. I think it's going to be a relatively short amount of time until telemedicine is covered just as well as any other medical service. This is our organization chart for telemedicine at the University of Utah. It's a relatively new chart, and I show it simply to make the point that we now have a formal telemedicine department because the university hospital sees the value of telemedicine not just in improving patient care and outcomes, but very frankly as a marketing and outreach effort. So this is really the slide that I was supposed to present at the first. What have we learned about telemedicine from this several-year effort? The first one is you need to have a plan. You ought to have a reason to do it. Telemedicine is really fun, and a lot of people think it's really cool, and it's sexy, and patients ask for it. But if you don't have a good reason to do it, you really shouldn't go through the trouble of instituting the program. It can do all of these things. It may not do all of them for you, and you have to decide which of these reasons to institute telemedicine you're going to have. Grant money has gotten many telemedicine programs started. It got our telemedicine program started. Many grant-funded programs fail when the money runs out. So even if you start your program with grant money, you have to have a plan for extending your program after the grant money runs out. You need to have a champion. The biggest problem with the institution of telemedicine, not just in Salt Lake City, Utah, but worldwide, really is the change in culture that physicians have to adapt to in order to utilize telemedicine effectively. And if you don't have a committed provider at one end or the other, the telemedicine program is never going to get off the ground. Similarly, I think you need a coordinator to help organize your telemedicine efforts, do your scheduling, take care of the technical problems as they arise, and try to keep those away from the physician as much as you can. As I say in number 6, you really want technology to be as invisible as possible to the participants. Even though I'm the director of the telemedicine service, I know almost nothing about technology. I don't know the difference between a T1 line and a DSL line, and neither do any of the other doctors that I work with. They just want to turn on the computer and see the patient and deliver the care, and we have the system organized in order to provide that. We want to integrate the care into the workflow as much as possible. That's why we're trying to put laptops and desktops in doctors' offices and in clinics as much as we can. I wouldn't worry much about the billing. Just send a bill with appropriate modifiers, and you'll very likely be compensated. And most importantly, you need to make this a personal service. Telemedicine is not about TV sets. It's not about computers. It's about one doctor talking to another doctor or one doctor talking to a patient. So go visit the sites that you're going to connect to. Talk to the doctors you're going to connect to. Be sure the patients understand that this is a personal service. Many of our physicians have been reluctant to embark on telemedicine because they view it as second-class care. They don't want to be accused of second-class care. And one of our best oncology physicians, who is now an enthusiastic supporter of telemedicine, initially was reluctant to do it because he said he wouldn't be able to hug the patients. So that kind of personal commitment will make a telemedicine service work. We've assigned someone at the remote site to hug the patients for him, and the telemedicine program is going very well. And I'll close with this very important quotation. This is from Jonathan Linkhouse, who's the CEO of the American Telemedicine Association. If anybody believes in telemedicine, if anybody is a prophet for telemedicine, it's Jonathan Linkhouse, and he says it's not about technology, it's about service. If you keep that in mind and you make telemedicine about medicine, I think it's easy to get the program to survive. Thanks very much.